I'm Amanda Bunton, for those of you that don't know me. Today's Grand Rounds, and I'm doing my Grand Rounds on pregnancy-associated breast cancer. This is also known as gestational breast cancer. Cancer in pregnancy is diagnosed in approximately 1 out of every 1,000 pregnancies. And because of the reproductive age of the woman, most of the time these cancers are breast, cervical, thyroid, and non-Hodgkin's lymphoma. Originally, I was going to do a presentation on these cancers in pregnancy in general, but then I realized the topic was way too vast, and in order to give a decent presentation, I really have to limit it to only one of these cancers. So I chose breast cancer because as a single diagnosis, it's the most commonly diagnosed cancer during pregnancy. This topic is important because we don't really see cancer in pregnancy a whole lot. It's something that we're not really comfortable with. And now is the trend for women is to start delaying childbirth in the later years. We're probably going to start seeing a lot more cancers during pregnancy. And also delayed first birth is itself a risk factor for breast cancer. So our objectives today are to identify the challenges in making a diagnosis of breast cancer during pregnancy. We will review the treatment options available to pregnant patients with breast cancer. Many of the treatment paradigms used in the non-pregnant patients can be applied to the pregnant patient, but you'll have to give consideration in the fetal well-being, so some modifications do have to be made. We will review the maternal and neonatal outcomes associated with gestational breast cancer and its treatment. Prospective studies are very limited in pregnancy because of the rarity, so a lot of the recommendations and data come from retrospective case series and case reports. And then we'll establish some basic guidelines for management of pregnancy and delivery for pregnant patients with breast cancer. This is an overview of the presentation. We'll talk about the definition and the incidence, diagnosis, how to stage, prognosis of breast cancer in pregnant patients versus a non-pregnant population, treatment, how treatment affects neonatal outcomes, delivery planning, whether or not pregnancy termination is beneficial, and breastfeeding. So pregnancy-associated breast cancer is breast cancer that's diagnosed during pregnancy, in the first postpartum year, or any time during lactation. Although breast cancer is one of the most common pregnancy-associated breast cancers, pregnancy-associated breast cancer itself is actually a rare diagnosis. So 10 to 20% of breast cancers are diagnosed 10 to 20% of breast cancers diagnosed in women under 30 are actually diagnosed during pregnancy, but only up to 4% of pregnancy-associated breast cancers are diagnosed in women younger than 30. Gestational breast cancer has an incidence of 15 to 35 per 100,000, and there are fewer cases diagnosed during pregnancy than in the postpartum year, and most of this is just reluctance to diagnose and biopsy and image during pregnancy. So as far as diagnosis goes, the index of suspicion has to be high for a pregnant woman with a breast mass because the physiologic changes in the breast during pregnancy and lactation result in engorgement, increased nodularity, and this makes physical exam more difficult, findings more difficult to interpret, and also may limit the utility of our imaging studies. Diagnostic delays are responsible for the advanced stage that breast cancer in pregnancy is diagnosed at. An average diagnostic delay of 2 to 6 months has been documented in the literature for pregnant patients. The most common clinical presentation is a painless lump. So when a patient presents with a lump, and especially if it's been present for more than 2 to 4 weeks, you should biopsy. The milk rejection sign is a sign that's been described in the literature where an infant refuses to nurse from a lactating breast because of a breast cancer, and this is postulated to occur because there's some change in the odor, the taste, or the consistency of the milk that renders it objectionable to the infant. Ultrasound is the preferred imaging modality to evaluate breast masses in pregnancy because it's safe, it's inexpensive, and the sensitivity and specificity are not altered by pregnancy. So it's got a 98.4% sensitivity rate, and the negative predictive value is 99.5%. It can differentiate between solid and cystic lesions. And as far as using ultrasound for pregnancy, that's all it should do. Like, just differentiate between solid and cystic. Because once you start looking at like solid masses to try to determine if they're benign or malignant, it's really not helpful, because a lot of receptor negative breast cancers, a lot of high grade cancers, and a lot of cancers that are in the younger women have findings similar on ultrasound to benign lesions, especially like posterior acoustic enhancement. That's not really a reliable indicator of whether a solid mass is malignant or not. And then ultrasound can be used for guiding, like fine needle aspiration of any palpable lymph nodes. Mammogram is safe to use during pregnancy. The average dose to the breast with a tube view is 200 to 400 millirads, and this results in a negligible dose to the infant of 0.4 of a millirad. And fetal exposure less than 5 rads are thought not to cause malformation. The sensitivity of the mammogram is altered because of the changes in the breast during pregnancy and lactation. So sensitivity rates range from 63 to 78%. However, mammogram is still recommended because it can detect microcalcifications, architectural distortion or focal asymmetry, as well as masses or multifocal disease. And a negative mammogram in the setting of a palpable mass should never be ignored. You still need to biopsy even if the mammogram or the ultrasound is negative. So MRI breast can be used if you need further imaging besides just the ultrasound and the mammogram. There are no published data regarding the use of MRI to diagnose breast cancer during pregnancy, so the sensitivity and specificities have not really been reported. But it still can be considered if further imaging is required. And they recommend MRI after the first trimester. There have been no harmful fetal effects from MRI when used during pregnancy, but the National Radiologic Protection Board advises MRI be avoided if possible within the first trimester, just because the effects of organogenesis are not known, but more than likely it's okay. Gadolinium enhanced MRI is more sensitive than mammogram for detecting invasive breast cancer, but since we can't use gadolinium during pregnancy, this is really only an option for our postpartum women. So a clinically suspicious breast mass should be biopsied for definitive diagnosis, despite negative ultrasound or mammogram. And biopsies can be performed relatively safely during pregnancy, preferably under local anesthesia. Core needle biopsy is the preferred method of tissue confirmation. FNA has been used, but it's unreliable because there are hyperproliferative changes in the breast. And so when the pathologist gets the FNA, they may come up with like an indeterminate score where they would need more information, and you may end up needing a core needle biopsy even after the FNA. And you may as well have just done the needle biopsy in the first place. And also FNA may be technically difficult due to engorgement during pregnancy. So after a breast cancer is diagnosed, which these tend to be diagnosed at an advanced stage just because of the delay in diagnosis, you need to stage the patient. Locally advanced stage, like 3 to 4, or patients with clinically palpable axillary lymph nodes or suspicious symptoms should undergo a complete radiographic staging evaluation. But those with early stage breast cancer, if they've got no palpable nodes and are asymptomatic, the rate of metastasis is low, so you can forego the staging evaluation. So the 3 most common sites of distant mets in breast cancer are the lung, the liver, and the bone. So you need to evaluate all those places. As far as evaluating the chest x-ray is the easiest. It can be performed safely with abdominal shielding. It only exposes the infant to 0.06 of a millirad of radiation. You do want to avoid CT chest and gadolinium. And so if further evaluation is required, MRI of the thorax is preferred. In order to look for liver metastasis, abdominal ultrasound is the preferred method. MRI without contrast can be done if needed. You don't want to do a CT abdomen pelvis because that confers a radiation dose of 250 millirads to the fetus. And then when we're looking at bone disease, low-dose bone scans, which are modified in that the mom gets an indwelling catheter to try to drain the radioactive material from the bladder, and they use 20 millicuries in normal bone scans. They drop that down to 10 millicuries of radioactive iodine with these low-dose bone scans. So low-dose bone scans or MRI without contrast are the preferred method to look for bony metastasis, but if needed, you can do plain skeletal radiographs. But when you compare the radiation dose from a low-dose bone scan to a radiograph, the low-dose bone scan is like 0.08 of a millirad compared to 1 rad with the plain skeletal radiograph. And then MRI brain for anybody with CNS symptoms. So most breast cancers in pregnancy are poorly differentiated, infiltrating ductal carcinoma, and this is the same as the non-pregnant population. The second most common is invasive lobular cancer. Women with breast cancer tend to have larger tumors, most frequently have nodal involvement, METs, and vascular invasion. And the theories behind the advanced size and stage of breast cancer in pregnancy relate to diagnostic delays due to the physiologic changes in the breast, as well as reluctance of the clinician to perform a mammogram or a biopsy while pregnant, as well as possibly creation of a higher, more aggressive tumor biology because of all of the endogenous hormones like the estrogen and progesterone being really high in pregnancy. Some studies have shown a higher rate of receptor-negative cancers in breast cancer in pregnant patients, while other studies have found that the rates are comparable, as well as the HER2 status being comparable to those without breast cancer. The prognosis of breast cancer has been addressed in several studies, and there's inconsistent results. The relative rarity of the disease kind of precludes a very well-powered study to address the question. But it's thought that women diagnosed during pregnancy with breast cancer stage 1 and 2 have a similar prognosis compared to their non-pregnant cohorts, but women with later stages may have a lower survival. It is very well documented, though, that women diagnosed within the first 2 to 3 years after delivery have a worse prognosis. So this was a paper by Rodriguez et al. Published in Obstetrics and Gynecology in 2008 called Evidence of Poor Survival in Pregnancy-Associated Breast Cancer. It was a retrospective cohort study. It compared stage distribution, tumor characteristics, and survival outcome in pregnancy-associated breast cancer and non-pregnancy-associated breast cancer. It was done between 1991 and 1999. The patients were followed through 2004. They included patients who had breast cancer diagnosed within the 9 months before delivery or up to 1 year after delivery. They ended up with 797 pregnancy-associated cases, and they compared these with almost 4,200 age-matched controls. It's a lot more common to find breast cancer diagnosed in the postpartum, so that group made up the majority with 610. 179 were diagnosed antepartum, and 8 were diagnosed at delivery, and that meant the delivery hospitalization. So what they found that there was no difference in the average time between diagnosis and surgical treatment, so the patients were being diagnosed and receiving either a mastectomy or breast conservation surgery. And there was no difference in the average time to start chemotherapy from diagnosis between the non-pregnant and the pregnant cohort. There was a difference in the two groups in the average time between diagnosis and start of radiation, which makes sense because radiation is really not advised in pregnancy, so a lot of people wait till after the patient delivers to start radiation, so that is why there was a significant difference there. And then the marked difference in the antepartum or at delivery cases compared to the postpartum cases makes sense, because if they're diagnosed early on in pregnancy, they're going to wait a whole lot longer till they deliver and then are able to start radiation. So women with pregnancy-associated breast cancer were less likely to be non-Hispanic white. They were more likely to have higher stage disease, larger primary tumor, mastectomy rather than other forms of surgical treatment, and hormone receptor negative status. And then they did a multivariable analysis, and they found that advancing stage, race, hormone receptor negative status, and pregnancy were all significant predictors of death. So here you can see being African American increased the risk of death by 68%. Hormone receptor negative status increased the risk of death by 20%. And advancing stage conferred a 2.2 to 10.8 times the risk of death for stages 2, 3, and 4. When all the other variables like stage, surgery, hormone receptor status, tumor size, race, and all that were controlled for, women with pregnancy-associated breast cancer had a marginally significantly higher risk of dying in their study, with pregnancy association conferring a 14% increase in risk of death. So their analysis kind of contradicted the earlier studies that kind of related the difference in survival to the difference in stage at presentation, because here they controlled for stage. And they figured that either immune suppression during pregnancy or just the more aggressive tumor biology because of the higher estrogen and progesterone levels, that maybe that was the reason why the pregnancy association led to increased risk of death, because maybe the estrogen and progesterone stimulated tumor growth or metastasis. This is a study by Azim et al., and it was published in the Cancer Treatment Reviews in 2012 called Prognosis of Pregnancy-Associated Breast Cancer. It was a meta-analysis of 30 studies. The literature consistently notes that women diagnosed within the first 2 to 3 years postpartum have a worse prognosis, and this is evidence as to that point. So they looked at 3,600 patients diagnosed with pregnancy-associated breast cancer, and they had a control group of 37,000 breast cancer patients that weren't pregnant. Their primary and secondary outcomes were overall survival and disease-free survival. Disease-free survival was defined as a date from the time of diagnosis to either a invasive locoregional recurrence, a contralateral breast cancer, metastasis, or any secondary malignancy. And then overall survival was diagnosed as the time from diagnosis to the time of death from any cause. And what they found that was that pregnancy-associated breast cancer had a significantly worse overall survival with a pooled hazard ratio of 1.44, as well as significantly worse disease-free survival with a pooled hazard ratio of 1.6 compared to the breast cancer controls. But then they went ahead and broke it down further to the women with breast cancer diagnosed during the pregnancy and then those diagnosed postpartum. And there was a clear trend of poorer overall survival in those diagnosed postpartum. So their pooled hazard ratio for the postpartum group was 1.84, and those diagnosed during pregnancy were 1.29. And you can see that the pooled hazard ratio of 1.29 didn't even make statistical significance. So it may be that just the worst prognosis is really due to these postpartum cases, and most of the studies are kind of grouping these two groups together. So when you look at those diagnosed during pregnancy and exclude the postpartum cases, it may be that they have similar overall survival. So this is what Amont et al. Did. This is a study published in the Journal of Clinical Oncology in 2013 called Prognosis of Women with Primary Breast Cancer Diagnosed During Pregnancy. Results from an international collaborative study. It was done in Belgium and Germany between 2003 and 2011. They had a case control study of 311 women with breast cancer and then 865 controls. They excluded the postpartum cases. They also looked at overall survival and disease-free survival, and they adjusted the results for the known prognostic factors like age and stage and histologic type and hormonal receptors, etc. And they found that there was no statistical difference in disease-free survival or overall survival between these two groups. They also did a Cox regression analysis, and that estimated that the 5-year disease-free survival rate for a pregnant patient would have increased from 65 to 71% had the patient not been pregnant. And for the 5-year overall survival rate, that would have increased from 78 to 81%. So their results showed similar overall survival for breast cancer diagnosed in pregnancy and then breast cancer in the non-pregnant population, which means that you should start treatment with continuation of the pregnancy. Pregnancy is not going to confirm a poor outcome. As far as treatment goes, therapeutic decisions need to be individualized. You need to take into consideration the gestational age of the fetus, the stage of the disease, and the preferences of the patient and the family. The goals, of course, are to control the cancer locally and prevent systemic spread. The treatment should closely follow the treatment in the non-pregnant patient, but there do have to be some modifications made to help protect the fetus. Treatment should be administered with curative intent with minimal delay. There was a study in the 1980s done by Nettleton et al., and they came up with this mathematical model to assess tumor progression over time. And they found that even a 1 month delay in treatment increased the risk of axillary mets from 1% to 2%. So that doubled the patient's risk of axillary metastasis, and axillary nodes are the most important prognostic factor in survival in breast cancer. Locoregional treatment consists of surgery. That's a definitive treatment for pregnancy-associated breast cancers. There doesn't appear to be a fetal risk when breast and axillary lymph node surgery are performed during pregnancy. You could either do mastectomy or breast conservation surgery for pregnancy-associated breast cancers. If the breast conservation surgery is chosen, then the patient needs radiation to that same breast in order to achieve optimal control. And then, like we talked about earlier, radiation does have to be postponed until that postpartum period because of the risks of fetal radiation exposure. However, if the patient chooses a mastectomy, especially if they're stage 1 and 2, they do not have to undergo radiation. And so a lot of earlier studies had recommended just going ahead and doing a mastectomy on all these patients preferentially, just so that they wouldn't have a big gap between surgery and starting radiation postpartum. So a lot of these patients would get surgery and then undergo anthracycline-based chemotherapy and then would have to wait like months in order to start radiation if they had undergone breast conservation surgery. But with mastectomy, they just go ahead and do everybody with mastectomy, give them the chemo, and then they'd be done. However, recent evidence shows that taxane treatment, which is used in the non-pregnant population, especially in the more advanced and the metastatic breast cancers, taxanes have more recently been shown to maybe be safe to use during pregnancy. So this is a newer option where you can go ahead and have breast conservation surgery, start your chemotherapy. After you've finished standard anthracycline-based chemo, you can start taxane treatment, and that'll buy you 8 weeks, because you can give up to 4 cycles every 2 weeks. And then you can go ahead and start radiation postpartum. If breast reconstruction is desired, then it should be delayed until after delivery, and this is just because you don't want to prolong surgery because it increases fetal complications. So you need to assess nodal status during the time of surgery because it provides useful prognostic information and it helps guide what adjuvant treatment's needed. Axillary lymph node dissection is a standard approach for anybody with clinically positive palpable axillary lymph nodes. For patients with early stage breast cancer and they don't have any palpable lymph nodes, sentinel lymph node biopsy is what's used in the non-pregnant population. And sentinel lymph node biopsy is superior to axillary lymph node dissection with respect to morbidity and quality of life for the patient. However, there's been controversy as to whether or not sentinel lymph node biopsy is okay during pregnancy. There's safety concerns, there's efficacy concerns. Some of the potential concerns, like, well, is there going to be fetal harm from the radiocolloid use and that radiation exposure? If they use blue dyes to perform the sentinel lymph node biopsy, is that going to be a teratogen? Isosulfan blue dye has a high anaphylaxis rate, and so if the mom goes into anaphylaxis, that poses a risk to the fetus as well. Most studies have concluded that the expected levels of fetal exposure would be below the 5 gray threshold, and so using a radiocolloid to do sentinel lymph node biopsy is probably okay. And then as far as the issue as efficacy goes, it's not really clear whether the lymphatic drainage in the breast is the same as the non-pregnant breast. So this may make performance of the sentinel lymph node biopsy harder and may make identification of that node more difficult. This was a study by Groper et al. Published in the Annals of Surgical Oncology in 2014 called Sentinel Lymph Node Biopsy in Pregnant Patients with Breast Cancer. It was the largest single cohort to date of breast cancer patients who underwent sentinel lymph node biopsy while they were pregnant. It was done between 1996 and 2013 in Boston, Massachusetts. Retrospective cohort study of 81 women with breast cancer during pregnancy. 47 of these women had clinically node-negative disease. So, like I said before, usually with node-negative disease, those patients, if they were not pregnant, they would get sentinel lymph node biopsy. Well, because they were pregnant, 20 just up front had axillary lymph node dissection to begin with. 25 underwent a sentinel lymph node biopsy, and 64 had the sulfur colloid, 28% had the methylene blue. Now you're thinking methylene blue is not really supposed to be used during pregnancy, especially like when instilled into the amniotic cavity, but the dose they're using with the methylene blue for this is like 50 to 100 times less than the dose used for injection into the amniotic cavity. 2 had unknown mapping methods, and then 2 had no nodal evaluation, and that's only because they had invasive disease. So there were no complications of the sentinel lymph node biopsy in any of the patients, and all the women had at least identification of one sentinel lymph node. 5 women had 1 or more sentinel nodes positive for metastasis, and then there was 1 woman who had a negative sentinel lymph node biopsy, but then they found a really suspicious node, and so they excised that and found cancer in that. So those 6 women went on to have full axillary lymph node dissections, and 3 of those had axillary mets identified, and that included the one with a negative sentinel lymph node to begin with. So like I talked about, there was that hypothetical concern that the physiologic modifications of the breast glands during pregnancy may alter the lymphatic drainage and decrease the accuracy of lymphatic mapping. So there was 1 instance of false negative sentinel lymph node biopsy in this study, which they think the single failure rate falls within the range of false positives in the studies of non-pregnant women. But there's really no way to tell their true false negative rate because they didn't make all the patients who'd undergone sentinel lymph node biopsy from the beginning get an axillary lymph node dissection. So they may have had more cases that they missed, and we just don't know it. Of the 25 pregnancies that underwent sentinel lymph node biopsy, 25 resulted in live-born infants, and there was only 1 case of a birth defect, and that was a baby born with cleft palate. That mom had other issues like methadone use, tobacco abuse, and as far as when the sentinel lymph node biopsy was done in relation to like trimester or whatnot, that information was not given. They concluded that sentinel lymph node biopsy appears to be safe and accurate with no maternal complications and generally excellent health in infants born. So adjuvant radiation improves local control of breast cancer as well as survival, but radiation is generally delayed until after delivery because of the unacceptably high risk to the fetus. The radiation sequelae to the fetus may result in pregnancy loss, malformation, disturbances of growth or development, or maybe induction of childhood or hematologic malignancies. However, if the clinician believes it's in the best interest of the patient, radiation is possible, but you've got to use fetal doses that fall below the customary threshold for malformations, which everyone kind of uses that 5 gray threshold, but there's really not a definite threshold at which an increased risk of congenital malformation is observed. The amount of radiation to which the fetus is exposed depends on the dose and the stage of the pregnancy that the patient is at when the radiation is given. As the pregnancy advances and the fetus moves closer and closer to the diaphragm, the baby gets more radiation. So administering 5 grays of external beam radiation to the breast in the first trimester will give you a dose of like 400ths to 1500ths of a gray compared to a 3rd trimester dose of 2 grays. Then systemic treatment will include your adjuvant and neoadjuvant chemotherapy. All the chemo agents used in pregnancy are categorized by the FDA as category D or X, and the teratogenic effects are highest in the first trimester. Outside of that window, surprisingly, these drugs have a very low risk profile. So the adjuvant chemo is recommended for anybody with node-positive breast cancer, those with tumors greater than 1 to 2 centimeters, and any tumor that's poorly differentiated. And the most commonly used regimen is doxorubicin plus cyclophosphamide plus or minus 5-fluorouracil. And they call this the FAC for the fluorouracil, the adriamycin, and the cyclophosphamide. There was a prospective study, the only one that I know of, that studied this chemotherapy regimen in pregnant patients. They had a total of 24 pregnant patients. They gave them the same doses as used in the non-pregnant population. It was not given in the first trimester, only in the second and third trimester, and they reported no birth defects in the infants when given the FAC regimen. Like we talked about earlier, taxanes are usually postponed till after delivery because their safety data is limited, but there are more studies showing that taxanes may actually be safe to use during pregnancy. And this is a study by Cardonic et al. That kind of demonstrates that. It was published in the Annals of Oncology in 2012. It's called Maternal and Fetal Outcomes of Taxane Chemo and Breast and Ovarian Cancer During Pregnancy. It was done at Rowan University in Camden, New Jersey. It was a retrospective cohort study evaluating the use of taxanes during pregnancy, and they wanted to look at maternal and neonatal outcomes in those who received taxanes and those who did not. Everybody in the study underwent like standard anthracycline-based chemo, but the women either received taxanes afterwards or did not. So they included women with ovarian cancer because paclitaxel is a treatment for breast cancer as well. So they ended up with 15 women with breast and ovarian cancer who underwent taxane treatment, and 123 women that were their control group. Treatment started at a mean gestational age of 24 weeks, and the average follow-up for the infants was 46 months. And as you can see, there was no statistical significance in gestational age at delivery or the birth weight between the taxane and the non-taxane group. Also, there was no statistical difference between preterm delivery, birth defects, IEGR, birth complications, or medical issues between the two groups. Birth complications, they categorized as like apnea, prematurity, hyperbilirubinemia, respiratory distress, neutropenia. Medical issues that they cited were mild speech delay, recurrent otitis media. So they had 15 patients in the ovarian and the breast cancer group, but here you can see there's 4. This was a set of twins. There was one twin with diagnosed with Asperger's and speech delay, but the other twin was developmentally normal. So the congenital anomaly occurred in 1 out of 15 infants, and this congenital anomaly was hypertrophic pyloric stenosis. IEGR was reported in 18.25% of cases, and these numbers were not statistically significant from the group that did not receive taxanes. Like we saw in that chart, birth weight, gestational age at delivery, rate of growth restriction, congenital anomalies, and incidence of neutropenia were not statistically significant between the two groups. So they concluded that taxane-based chemo does not appear to increase the risk of fetal and maternal complications when compared with just conventional anthracycline-based chemo. So chemo is usually deferred during the first trimester because it carries the greatest risk for miscarriage and fetal death from chromosomal abnormalities or congenital abnormalities. One review reported a 1.3% risk if you used chemo in the second or third trimesters compared with the 16% risk if used in the first trimester. Clinicians should really recommend against delays in the initiation of chemo because it's associated with significantly worse disease-free survival and an increase in the risk of metastasis. And the treatment course may need to be altered due to pregnancy. For example, if a patient's diagnosed in the first trimester of pregnancy with breast cancer, they should undergo surgery and then postpone chemo until the second trimester. Even if your preference, had they not been pregnant, was to go ahead and give neoadjuvant chemo and then go on to surgery. You kind of have to flip-flop just so that you don't, you try to avoid the chemo during the first trimester if possible. So this was a study by Beadle et al., published in Cancer 2009, called The Impact of Pregnancy on Breast Cancer Outcomes in Women Less Than or Equal to 35 Years of Age. It was a retrospective study of 668 patients younger than 35 with breast cancer. They had 104 pregnancy-associated breast cancers. All the patients were treated with locoregional treatment, either with mastectomy, breast conservation surgery, or mastectomy with radiation postpartum. And then as far as chemo and hormonal therapy, that was left up to the physician's discretion. They had a median follow-up of 114 months. So there were 51 patients who developed breast cancer during pregnancy. 25 of these patients received no treatment whatsoever, and then 26 received some sort of treatment. So either they got chemo, they got locoregional surgery, or they ended up with a therapeutic abortion and then like some sort of treatment afterwards. There was a trend toward overall improved overall survival for those patients who received any treatment compared with just delaying treatment until after delivery. So that was 78 versus 45% increase in the overall survival between the two groups. Although this wasn't statistically significant, it may be just because it was a low-powered study. So this kind of goes to show that you shouldn't delay treatment in pregnant patients. The study also kind of looked at the outcomes and staging and all that, and they found that TNN classification and stage were higher, which supports the studies that we went over earlier. Also, there was no statistical significant difference between locoregional recurrence, distant METs, or overall survival with the pregnancy-associated breast cancers when you compare those with the non-pregnancy-associated breast cancers. So just like the studies I went over earlier, they seem to have similar outcomes with regards to locoregional recurrence, distant METs, and overall survival. Pregnancy-associated breast cancer presented with more advanced disease, like we already know. The largest risk is the delay of diagnosis, and again, delaying treatment does not afford a survival advantage. So treating pregnant women with chemotherapy is more complicated because of the increased plasma value, decreased gastric emptying, decreased serum albumin. So dosing during pregnancy is kind of controversial as well. They recommend that doses during pregnancy should be based on height and actual weight as opposed to ideal weight or pre-pregnancy weight or something else. Dose-dense therapy is used in non-pregnant patients with advanced disease, and this is when patients get chemo every 2 weeks instead of every 3 weeks. There doesn't appear to be an increase in risk of maternal or neonatal complications with dose-dense therapy. It's infrequently used during pregnancy, but not contraindicated. Okay, so trastuzumab, this is Herceptin for the HER2-neu breast cancers. The use of this during pregnancy is not recommended because it can result in oligo. There were only 4 case reports on the use of Herceptin in pregnancy. No fetal abnormalities were reported, but reversible oligo was found. And since the oligo was found, there's been an FDA advisory against the use of Herceptin. So it's not recommended that that drug be used. If a patient does conceive while using Herceptin, the drug just should be discontinued and the pregnancy can be maintained. For women with hormone receptor positive breast cancers, tamoxifen and LNHR agonists, aromatase inhibitors, those are deferred until after delivery. Okay, this is a summary with the algorithm for treatment of breast cancer. So it really depends on gestational age of the patient. So if we're in the first trimester, you want to avoid chemo, you want to avoid radiation. So if it's an operable breast cancer, you get surgery. And again, mastectomy used to be the preferred treatment, but now breast conservation surgery can be performed as well. And then you would do adjuvant chemo after the first trimester. If they're in their first trimester when they're diagnosed and the breast cancer is deemed inoperable, then you have to wait until the second trimester. At that point, you could start chemotherapy and reevaluate them for surgery after delivery. If they're in their second or third trimesters and they're operable, go ahead and operate on them and then start chemotherapy. And if they're inoperable, you can just go ahead and start chemotherapy and then reevaluate for surgery afterwards. So the majority of pregnancies result in live births with low related morbidity in the newborns. Neonatal outcomes are mostly determined by what gestational age they're at delivery. In utero, exposure to chemo does not appear to affect the normal development of the baby, either physically or neurologically. And there was a study by Amont et al. He was the author of the second study that we looked at. He performed postnatal echoes on these children exposed to doxorubicin, because as you know, that can cause cardiac toxicity in the moms. And all the postnatal echoes in these 70 children were normal. He also did developmental testing on these infants and found that the majority were normal, and those that kind of scored a little below normal were concentrated in the group that had delivered preterm. So this is another study by Hahn et al., published in Cancer 2006. It's treatment of pregnant breast cancer patients and outcomes of children exposed to chemo in utero. It was a prospective study and it included 57 patients treated with the standard anthracycline therapy with FAC. They were only treated in the second or third trimesters. They conducted a survey of the parents and the guardians of these exposed infants to determine their health and development and their educational performance. The median gestational age at chemotherapy initiation in this group was 23 weeks. They ended up with a median of 4 cycles of chemo. And here they had, you see they had no stillbirths, miscarriages, or perinatal deaths. Gestational age at delivery and birth weight at delivery was not really different from the reported normal general population at that time, and the rate of neonatal complications and congenital abnormalities was also very similar to the incidence reported among the general population. All the parents and guardians who responded to the survey, which they had a 93% response rate, felt that their child exposed to chemo in utero was healthy. They had one child with Down syndrome and one child with ADHD who required special attention at school. But other than that, everyone else thought that their child was comparable in development to other children their age or to their siblings. So they concluded that pregnant women with breast cancer can be treated with anthracycline chemotherapy in the second or third trimester with relative safety for both the mother and the fetus. Timing of delivery, it really depends on the maternal condition, the need for further therapy, the expected neonatal and infant outcomes at that gestational age. But the definite recommendation is that you don't want to deliver before 34 weeks, and you want to demonstrate fetal pulmonary maturity. A delivery should be planned 3 to 4 weeks after chemo, and this allows the placenta to metabolize the chemotherapy so that you can recover your cell counts, and then there's less risk of neonatal myelosuppression and infection and death from that. So a patient who completes chemo by 32 to 33 weeks can be delivered by 35, 37 weeks in order to start chemo. Administering chemo after 35 weeks is not recommended, just because you want to give yourself that 3-week window for the placenta to metabolize it and then be able to deliver at 37 weeks or after. And then chemo can be resumed 7 days after delivery. C-section is reserved for the usual obstetric indications. Okay, so this is a big question, whether or not terminating a pregnancy is beneficial. So termination decisions should be individualized. It's going to depend on the patient's willingness to accept a possible risk to the fetus from the treatment, her overall prognosis and the ability to care for the baby afterwards, and the effect of the breast cancer treatment on her future fertility. Early termination of pregnancy does not improve the outcome of breast cancer in pregnancy. Some theories suggest even decreased survival in pregnant women who electively terminate their pregnancies when you compare those with those who continue the pregnancy. But these studies are retrospective and they can have bias, and it may have been that the women with a more advanced disease were kind of counseled to abort, and so of course it's going to show that they have decreased survival. And the stages of these women really weren't reported in the publications. So Zemlickas et al. Did a study called Maternal and Fetal Outcome After Breast Cancer in Pregnancy. It was published in the American Journal of Obstetrics and Gynecology in 1992. They compared 118 women with breast cancers with 269 non-pregnant controls, and they looked at fetal outcomes and maternal overall survival. But I'm not really interested in that because we went over like 5 studies going over outcomes and maternal survival. So here we're just looking at the 119 cases of gestational breast cancer. They had 42 diagnosed during pregnancy. So with the 42 diagnosed during pregnancy, 32 of those patients maintained the pregnancy. And then 10 of those terminated, either electively or spontaneously. And then when they looked at the survival between these two groups, there was no statistical significant difference when they compared the women who had terminated to those who had maintained the pregnancy. And this is a Kaplan-Meier curve showing the survival for the two groups. As you can see, there's really not a statistical significant difference. So termination of pregnancy was not associated with improved survival. And this makes sense. A lot of people think that pregnancy may confirm a worse prognosis just because of the increased progesterone and estrogen environment during pregnancy, but then we've also shown that most breast cancers in pregnancy are hormone receptor negative. So if they're hormone receptor negative, then they really shouldn't respond to the estrogen and progesterone, and therefore pregnancy shouldn't really affect the course of the disease. Breastfeeding is not recommended while undergoing chemotherapy, but for women who have completed chemo and have given themselves that substantial amount of time, like that 3-week interval, to allow metabolism of the drug, they can breastfeed after that. Breastfeeding does not affect the prognosis of breast cancer. Many women are able to produce milk from the treated breast, but the amount of milk may be reduced, especially if the surgery excised some ducts close to the areolar complex. If a woman is undergoing radiation, breastfeeding is not contraindicated, but it is recommended that they breastfeed from the other breast, because if they breastfeed from the irradiated breast and they develop mastitis, that's really, really hard to treat. If a patient's going to undergo further breast surgery after delivery, then breastfeeding is discouraged because engorgement would make the surgery more difficult to perform. And then you do want to avoid the endocrine and hormonal therapies like Herceptin, tamoxifen, the aromatase inhibitors and all that, because they can suppress lactation and their excretion into the breast milk is really not known. And then last, getting pregnant after a diagnosis of breast cancer. They recommend that you at least wait 2 to 3 years after initial treatment, and this is just because most recurrences, if they're going to occur in the first 2 years. Women who become pregnant after successful treatment of breast cancer do not have a worse prognosis with regard to their cancer. So just to hit some of the high points of the presentation, because it was a lot of information, pregnancy-associated breast cancers are diagnosed at an advanced stage, and this is mostly due to diagnostic delays. Prognostic data, comparing pregnant patients to non-pregnant patients, overall survival and disease-free survival have shown inconsistent results, but it may be that the groups just need to be broken down into those diagnosed antepartum and those diagnosed postpartum, because postpartum seem to have a worse prognosis, and those diagnosed antepartum seem to have a similar prognosis. Treatment of pregnancy-associated breast cancer should follow closely the guidelines of those in the non-pregnant patients, but there does have to be some modifications made to help protect the fetus. Termination of pregnancy does not improve outcomes. avoid deliveries before 34 weeks, and chemotherapy is pretty much is safe to use, especially in the second and third trimester. So the major take-home point is breast cancer can be treated during pregnancy. You do not have to terminate pregnancy in these patients. Have a high index of suspicion when a pregnant patient presents with a breast mass because a delay in diagnosis increases the risk of metastasis, and do not delay treatment for these patients just because they're pregnant. Most of the treatment regimens are safe and can be used while pregnant. Here are my references. Any questions?
I have a question. It was very good. I'm sorry I missed the first part. But you showed some data that said when radiation exposure is probably minimized earlier on because of when the fetus comes up, and that they didn't seem to see any effects in the newborns. How old were they going in those newborns, though?
That study, I want to say, followed them up to like 4 years.
Okay. So they're not just looking newborn, they're looking...
Yeah, they followed them out for some time. Some of them, they ranged because some of the, I think, more specifically, I think some of them were like 2 months, but up to 4 years of age. So everybody was at a different gestation, like different age, just of what information they collected. It was retrospective.
I remember that sometimes the biggest risk for radiation exposure is childhood leukemias.
Yeah.
It's interesting.